Good afternoon. Good afternoon. I'm Terry and I cover Auckland South and Franklin. I'm one of the community educators for Parkinson's, and I was just asked to MC today. So today is a celebration of James Parkinson's birthday, and all over the world and all over New Zealand, on April the 10th or close to it, there are a number of activities. Some places they're doing walks and other places they're doing expos, but in Auckland we have a public lecture on an aspect related to Parkinson's. I've heard Barry Snow talking about Parkinson's and the history of Parkinson's research. Last year we had a urologist and some continence nurses talking about plumbing and Parkinson's. And this year we are privileged to have Dr Jackie Allen, who is a laryngologist, and Dr Anna Miles, who is a speech and language therapist. They're going to do a shared presentation. And they've asked if you could hold on to your burning questions until the end of their presentation, and they've allowed plenty of time for your questions, but if you could just hold on till then, that would be great. Someone will whiz around with another mic when you've got your questions so that you can be heard. So briefly, just some housekeeping. To go to the loo, there's a door over there that will lead you to the loo, or you can go out through the foyer and turn left. There won't be a fire alarm, but you know, there's the exits, should there be. So yes, welcome again, and I hope you enjoy the lecture. I've thought the last two were very good, and I think we're well served in the Parkinson's community in Auckland by the number of health professionals who have a very strong interest in Parkinson's and helping those who have Parkinson's. So if I can welcome Dr Jacqueline Allen and Dr Anna Miles to the stage, and they'll take it from here. Thank you very much.
Okay, thanks Terry, and thanks to Bev and the team for inviting Anna and myself to come along and chat today. I wasn't 100% sure of the format, so there's some information, and I'm sure that a lot of you already know quite a lot about Parkinson's, so this may be redundant for some, but we thought we'd concentrate a little bit on some aspects that might be a little bit more novel and some things that we're doing in the research sphere so that you know what's happening in Auckland, and if anyone wants to get involved or participate or find out more about it, then as Terry mentioned, we'll have plenty of time for questions so that people can find out if it's something that is interesting or maybe holds promise for themselves or people they know, friends and family. So I'll just introduce myself further. So I'm a laryngologist, so that's an ENT surgeon. I have a special interest in voice and swallowing disorders, and that's primarily what I look after. So amongst all of that, of course, several of my patients have neurologic illness and they have Parkinson's disease. So we spend some time looking after these patients, and we fully recognise that there's many manifestations and a lot of different symptomatology, but we primarily are there to help around the voice and swallow. Anna is a PhD speech scientist as well, and she has a lot of experience in managing the condition too, and is driving a lot of our research in that area, and she'll talk lots more about the hands-on things that are going on right now. We did think it would be easiest for questions at the end, so because we may cover some of the questions that come up along the way. So I'll just flip on here. And these are probably facts that most people are familiar with, but Parkinson's disease is very prevalent. It's actually the most prevalent movement disorder. And in the United States, the estimated prevalence is around 1 million people and about 5 million worldwide. And in New Zealand, somewhere between 4,000 to 8,000, because there's about a point prevalence of 100 people affected per 100,000. Over the age of 60, it's about a 1% prevalence, so it increases with age, and that's what we all recognise and know. As Terry mentioned, James Parkinson was the neurologist who described this as a shaking palsy in 1817, so his name is attached to the disorder. But there are descriptions that date back 5,000 years, so it's obviously been a long, a long history of this. When I was just Googling around for things around facts around World Parkinson's Day, I looked on Google at many symptom pages, and people have probably been on the internet and looked, and I thought it was very interesting that I looked around 20 different symptom pages from United States university websites to the NIH, and only one of these symptom pages actually mentioned swallowing problems or voice problems as part of the spectrum of Parkinson's disease. And I thought that was fairly interesting. I guess I'm focused down on that, and everyone thinks about Parkinson's affecting mobility. But really, the voice and swallow aspect of this can be quite debilitating and be a really difficult area to manage. Most of our social interactions in life are around talking and eating with people, and if those are the things that are affected, it's hard to get on with your daily life or to interact with family and friends. And some of the things you may not know, but that the primary cause of death in people with Parkinson's disorder is actually an aspiration pneumonia. So this is usually due to poor swallow, and then you get a pneumonia because food is misdirected into the airway, and this is one of the things that we really try and act against and spend a lot of time treating. So the most life-threatening aspect of Parkinson's disease is the dysfunction of people's swallow, and we feel like that's an important area to focus on. And speech disorders, of course, can be socially isolating, and people may know the term Parkinson's hypophonia, which just really means the low voice that can develop over time. There's a loss of volume, of projection with the speech, and in the sustenance of speech. So people tend to have shorter phrase sentences and be harder to compete in background noise, which is also in things like conversation or when one goes out and there's background noise in a cafe or other social situation. So people sometimes come in. A lot of times the patient themselves is less bothered than their family or their partner, for instance. And as we know, if you're getting a bit older, then sometimes your partner might have hearing loss, and it's a bad combination, a low voice and hearing loss. So sort of a double whammy there. So this is an aspect that we also look after. The video that's showing there is actually a barium swallow or a modified barium swallow, and it's showing somebody swallowing the bolus that we watch, and that there's a bit of an obstruction at the top of the food pipe. So we all have a valve up high, and that area can get tight over time, and it can be a real problem for people swallowing. Now we all know this, Parkinson's disease is all in your head, right? It's all that basal ganglia function that's really a problem. And these are key controllers of a lot of patterned movement, and it's exactly the same as with swallowing. There are central pattern generators for swallow, because we don't usually think about our swallow. It happens in a programmed fashion most of the time, and we really rely on the body being able to coordinate that, make it happen in a timely fashion, and importantly, to keep it out of our airway, because we've got a design fault. Unfortunately, as we stood upright, our airway got right in the front of where the food needs to come, and so what can happen is if it can't get into your food pipe, the only other place food's got to go is forward and into the airway. And the vocal cords, although we think they're there for talking, they're really there to protect your lungs and to shut the door and stop it getting down there. So if those vocal cords get weak or they don't close, they also can't protect us when the food is accidentally misdirected. So the treatment modalities that we know about in general are drugs, so lots of medications directed at Parkinson's disorder, deep brain stimulation, so Barry might have talked about that because he runs a program in New Zealand. And even in the States, there's a lot of research on stem cells. Could we replace the neural cells that have been damaged or lost? And could we get our substantia nigra working? Can we get the dopamine back that we need? And so this is areas of research. But the important thing for speech and swallowing is that none of these have shown strong or long-term impacts on the speech or swallowing symptoms. Unfortunately, while they're really good at helping mobility, they don't seem to be as effective for speech and swallow problems. So as I mentioned, swallowing, dysphagia just means difficulty in swallowing, and it can be to different degrees. It could just be the odd pill that's getting stuck and that's a bit tough and you're careful and you know how to manage it. It could be solids, or in the worst cases it gets very hard to swallow even liquids, and then you can be coughing or choking when you're drinking and eating, and that has a negative impact on being able to finish a meal. Sometimes the symptoms might be regurgitation of food or choking when one eats. This can be associated with weight loss, over time because it gets harder and harder to manage a full meal. So you might take longer and then eat less and less volume, and you just lose weight gradually over time. And there can be saliva issues, either a feeling that there's too much mucus pooling in the throat and people really get bothered by that, or even that it's getting very thick and sticky and it can be hard to manage that. And this can lead to the big worry, which is chest infections. So in this video here, we're seeing inside someone's throat, it's their voice box in the front. They're trying to swallow some green coloured food, which is just apple puree, and you can see that it's stuck around the epiglottis, stuck in the throat. They're coughing to keep it out of their airway, but as they say E, a whole lot of this green puree just pops back up out of their esophagus and around the outside of their vocal cords, and they're getting a lot of regurgitation from a little pouch where that valve is tight. So they have to repeatedly swallow the same mouthful over and over again, and you can imagine that's extremely tiring and really makes it hard to get through a full meal. In terms of things that I might see when I look, if you come to see me in the clinic, I'm going to put a tiny little camera telescope in through your nose, and I'm going to look at your vocal folds, and I'm going to see what you're doing when you're swallowing. And the top two pictures there show a pair of thin but normal vocal cords and then the trachea or the windpipe. And what's happened down the bottom is that we've had to inject a little bit of implant into those vocal folds to try and fatten them up so that they can contact a bit better. And this is to try to help people speak with a bit more volume and to make it not as tiring to speak. Because characteristic things that we do find is that those vocal folds really thin out. Now, everybody's do over time. We all lose a bit of collagen as we age, but for some reason in Parkinson's, that seems to accelerate and the vocal folds get very thin quite fast. So the voice can end up being very whispery. And that's a lack of contact and breath control. This also means that you lose a lot of air with every time you speak, so it's really tiring to talk because you keep having to take a lot more air in to drive your speech. In terms of swallowing things, what we see is a bulking up of the muscle at the top, which narrows the inley. It's just plumbing again, a bit like the urologist, I suppose, where the food's coming down to a little area, which is the narrowest part. And the narrower that gets, the harder it is for food or fluids to get through it. We can see this area then blow out and have a little pressure release, which is the formation of a pocket or a pouch. And food or pills can sit in that and then suddenly pop out later, and that again can result in choking or cough. When I looked at some of the therapies, I mean, you can see here that these are really just talking about drugs alone. And there's about 15 listed on the one side there. And all of these are being tried in some way or another for treatment of Parkinson's. And one thing that tells me is none of them work really well, because if you need lots and lots of different therapies, there's no great good therapy. If there's one home run, then everyone uses it. So this tells us that people are looking at all different aspects, but there's nothing that's a really home run at the moment. There's drugs that help to increase the dopamine. There's some that stop the breakdown of the dopamine. There's some that stimulate the receptor of the dopamine. There's some that inhibit the breakdown from the other neurological thing. So there's loads of different things, but none of these are home runs. Currently, from a speech or swallow perspective, options that we do have and that we use to look at voice therapy. And Anna will talk about this. There is a very effective voice therapy technique called Lee Silverman voice technique, sometimes modified to be called loud. And this does seem to have a really good efficacy in patients with Parkinson's. And Anna will talk about that, and we are studying the effects of that in detail, including how it affects our swallow. From my perspective, if you get to my clinic about this, you're going to be looked at and could I offer a surgical option for this? And usually what we're talking about is what I mentioned before, which is injecting the vocal folds to plump them up, or putting in a little bit of implant, something like a little medical grade Gore-Tex to help give better contact. The reason we might use Gore-Tex is because it's long lasting and it's inert versus some of the injectables which we can use that are very short acting, so several months and they're dissolved away. So there's a few different options there to try to help the vocal folds get in contact. We don't have something that makes things move faster because we don't have good nerve pills. We don't have good things that just get things going quicker. So we're really pretty mechanical with what we can do in terms of treatment. From a swallow perspective, we can address that tight valve. That's a plumbing problem, and I can target that directly. So this video is showing you the big piece of muscle there, that bar. It's called a cricopharyngeal bar. It's at the top of the esophagus. It's so blocking that it's a big, thick wad, and we're using a small laser here to divide that and split the muscles. And that's really effective, and it helps food to get through over time. So people do quite well with that, but it is a surgery. It is invasive. People have to stay in the hospital a night or two to get over that. Other options are to modify food, so that means that you're just more careful in the way you manage food. You cut it small, you chew it well, you use plenty of lubrication. Dry food and crumbly food are always much more difficult, so you've got to be mindful and careful. You've got to change the pace of your eating so that you eat with a little less speed and a little bit more care, and you have to make sure that you're not throwing your head back to get food through because it will get jammed up in the airway. If people are struggling to get a good volume in and there's weight loss, we might use some supplements, something with good protein in it that's going to help to keep muscle tone and strength as good as possible, because if you eat less, you also lose muscle strength, and that's just a negative cycle. Other things we can do if that muscle's a bit tight is we can put a little balloon in there and stretch it up, which sounds a little weird, but it can work very nicely, and a little Botox, so you can have a very young looking throat again for a while. And that's sort of shown on here. So there's a little balloon device on that left-hand photo as you're looking. It's expanded in the tight area. We only need to inflate it for 60 seconds and it'll stretch that muscle out like a rubber band. And that'll last for a good 9 to 12 months. This is very non-invasive. It doesn't cause a cut or an injury, so people get over this much more quickly. Very short anaesthetic. Versus the opposite picture where we've really cut the muscle fibres there. So that's divided it. It's a longer procedure, it's a little more sore, but the results are long lasting. But we think that there's a really room to start thinking a bit laterally here and say to ourselves, what other things could we do? What other things can we offer? And one of the things that I looked into when I was working in California, and we now have ethics approval to use this device, is that we developed a tiny little plate, and with you see a pin there, and this can be sewn onto the cartilage in the base of the neck here and used to literally pull open that valve that's a bit tight. So you have a little pokey little bit of pin sticking out, as you can see in the sheep neck that we did in first, down the bottom there, poking out, so it looks like a wee piercing about here. You can physically hold that and pull that forward. And when we did that in the sheep, which is the video on the side, we can see that we can go from somebody aspirating, when we pull this open, to all the food passing in the food piping staying away from the airway. So this allows us to stop aspiration or the food going into the airway. So this is not something for everyone, but if people are really struggling with the swallow, this gives us another option, and this can be put in under local anaesthetic, and it's a very short operation. So we're looking at this in people who have severe swallow disorders. The other thing we know is that the LSVT had a good result for voice production, but we thought, well, what is that doing? It's a strengthening thing. It's using muscles around the voice box, and the other thing that those muscles do is they help us swallow. So we postulated that the LSVT is having an effect on swallowing, and that's currently one of the studies that we're looking into, because a therapy program that might actually help swallowing would be fantastic. It's non-invasive, and if people can get benefit from that, it offers us a great treatment option. There's also a look into areas such as something called prehabilitation. So instead of having rehabilitation, when you've gone through something and you need to get stronger at the other end, we can sort of pre-work on that. So do something preemptive. Rather than waiting for everything to give out and to get to a point where it's hard to come back, we could look at therapy that's very targeted that might actually prevent loss of muscle tone or prevent dangerous swallow practices developing. So this sort of high-risk groups that haven't developed the problems yet might be targets for this type of input. And the other thing that's important and sometimes forgotten, but your dentist might bring it up, is around lubrication and oral care. Because if you start to get very dry in the mouth, which is a side effect of many medicines that are given for Parkinson's, it's much harder to manage your food. If it's dry and sticky, you can't even get it out of the mouth or get it into a good ball to swallow. So these types of simple things, lubricators, oral gels that help to lubricate, even using moisturisers when you eat, can be really useful, and they can make a difficult meal into much more of a manageable meal. And these are things where areas where people are researching, and there will be things that develop nicely over time that we can use. So I'd just like to acknowledge briefly some of the funding assistance we've had, plus also the staff that help at the hospital, particularly where we've done a lot of this work, and Anna's faculty of psychology, who's also, their students have done a lot of our work as well. And then I'd like to ask Anna to come up and just talk a wee bit more about the targeted research that we're doing, so they can give you a bit of a broader spectrum, and then we can take some of your questions. Okay.
Thank you for inviting us to talk to you today. My name's Anna, and I'm a speech-language therapist by background. I work at the University of Auckland full-time, teaching the students and researching. My specialty area is swallowing and speech disorders, primarily in adults. And I've been working with people with Parkinson's disease since I first graduated. It's a very common disease in the UK and here, and it's something that we learn to treat from the very beginning of our training. I get the fun bit. Jackie had to talk about what we know. I get to talk about what we do. So one thing we do is we support people with Parkinson's disease with advice. So you'll find on your Parkinson's New Zealand website some advice sheets on managing swallowing disorders, managing oral cares, managing speech problems. But we go a lot further than just providing generalist advice. And I'm going to show you a few of the things that we can do to help. At the University of Auckland in speech science, we have a wide range of opportunities. Our students get the opportunity to participate in a lot of clinics as part of their training, which is a wonderful opportunity for them and gives us a chance to help our community and support our community speech therapists who are always striving to give the best they can to the community. So in our Tamaki clinics, we have a range of facilities. These are students all working with people in the clinics with a one-way mirror, so there's a whole load of other students watching from the other side, which can be quite daunting, but a great way for people to learn. So instead of learning from a textbook and learning from a lecture, they learn by actually watching clinics that are running every week. You can see on the left-hand side we do some work via Skype. So we do therapy over the internet for people who live too rurally to get in. We also know that intensity is important, so sometimes we use Skype to give people an extra therapy session that they wouldn't have got if they'd had to travel to us. We do some group sessions, and we do a large amount of what we call swallowing boot camp. And on the right-hand side, you can see someone doing some swallowing boot camp using surface EMG, which allows them to see their swallow on the screen every time they swallow, and we can work on bigger swallows or better-looking swallows. We also do boot camp on the road. At the end of every year, we take our equipment and we go around to people's houses who couldn't come into therapy in the Tamaki clinics. So I'm going to run through some of those options that we have. We have a swallowing and nutrition clinic. So one of the advantages of working in a university clinic is that we have the students from the other disciplines there too. So we work with our nutrition dietitian students, and we offer one-off advice sessions to people with Parkinson's disease, where they will get a full review of their nutritional intake and their swallowing at the same time, and we provide advice on both. We have a gavel club, a movers and shakers gavel club. Now, there are some of the therapies we do are really rehabilitative. They're really trying to improve your muscles, really trying to help you strengthen yourselves. And other things we're doing is really trying to help you to live with the problems you're having, or improve your communication at a more general level. Now, Gavel Club is supported by Toastmasters, and this is an opportunity for people to take the work that they're doing with their individual therapist and use it in a social situation. So there's a mixture of prepared speeches, impromptu speeches, and of course a large emphasis on tea and coffee and morning tea. So they meet every week for a couple of hours, and it's a really social group. And anyone who thinks that that's something they'd want to do, please let me know, because you're always very welcome. We do quite a lot of group work. So this is another opportunity that's come from the fact that we don't work independently as speech therapists. So this is the breathing and balance group. It involves physio and speech therapy students and their expert tutors, and they meet once a week and have a group exercise group. people have their own goals, but they're working within a group. It has some mindfulness aspects to it, and some principles of Tai Chi. So it's a really interesting group, and again, there are spaces in all of these groups if people are interested. We have a new opportunity at University of Auckland called the Expert Teacher Clinic. And this is a bit different because this is asking you to help us. There's a lot of literature on patients becoming the teachers of doctors. And we're taking this on, and this is our second year running this, looking at people with Parkinson's disease coming into the university and being the lecturers in small groups and teaching the students through small group work. And it's been extremely popular and working really well for both the people with Parkinson's disease and the students who just love the opportunity to sit and talk to people properly about what living with Parkinson's disease is like. So that's a fabulous new enterprise. And now I'm going to tell you some of the rehab things that we do, so the bits where we try and change your muscles for the better. As Jackie said, two of the most common symptoms that we see are the quiet voice and the swallowing problems. So Jackie and I had this idea that if the Lee Silverman voice treatment, the Think Loud treatment, which was meant to make you speak louder, could strengthen the muscles in the throat and the vocal cords enough to make you speak loud, would it also have an impact on your swallowing too and your cough? Having a weak cough puts you at much greater risk of chest infections, and we really wanted to see Lee Silverman is quite a popular option. People like it. So if it also helped your health because it got your cough and your swallowing stronger, this could be a great option for people. And we know that adding medications is not going to help the speech and swallowing aspects of Parkinson's disease. So Lee Silverman is a really intensive 4-week program where really you're told to think loud. And all you do is you sit with a sound meter in front of you, and I know some of you in the audience have done this treatment, and your aim is to look at that sound meter and get louder each day. So you're really trying to improve the strength and loudness of your voice, and the sound meter sits as a feedback, so every time you make your sound, you can immediately see how loud you've got, and this carries on, and you try and get stronger and stronger. So there's someone doing the therapy with the sound meter in front of them and really trying to improve the strength of their voice. So at the University of Auckland, we're looking at people before they've had the treatment and after they've had the treatment and seeing if their cough, and you can see on the right-hand side someone's having their cough strength tested, whether their cough and whether their swallowing improves. So we have 20 people enrolled. We've finished enrolling in this project now, which is fabulous. And we're trying to see if we can improve the strength of their swallow, cough, as well as their voice. We take people into the X-ray department, and we're having a look at a large range of measures of their swallowing before and after therapy. And the results are looking really great. So far, we're seeing what we expect to see, which is your decibel levels, your loudness is improving across a range. People's description of their swallowing is significantly improving, and people's description of their general Parkinson's symptoms are improving. And often we see these improve with people when they're happy with the results of therapy. Overall, they feel better about all of their symptoms, which is a nice thing about quality of life. When we're feeling happy, our symptoms feel less of a problem to us. And that's why anything that improves your feeling of how well you're doing is well worth the effort. And so far, we are looking as if we're seeing that tight sphincter that Jackie was talking about. all those gory photos of all these crazy laser treatments you can have to that sphincter. We're seeing an increase in the opening of that with the Lee Silverman, and I promise you I would rather talk loud into a microphone than have Jackie's laser near my throat if I could get away with it. Now, surgery is really important, but if we can find non-surgical ways to improve these things, then we're moving in the right direction. So my final description that I'm going to give you is a really fun way to improve yourself, and that's with the Celebration Choir at University of Auckland. Now, anyone who likes singing will choose singing over therapy, over talking loud into a microphone, over having a laser surgery. So if we can prove that this choir improves outcomes, then we've found a miracle cure for many people, because this choir is so much fun. You walk in and you can't stop smiling. You walk out and everybody's smiling. It's a choir for neurological disease, so you don't have to have Parkinson's disease. It also involves people's partners, and it is a very sociable event run by our really experienced music therapists. We're having a little look at the choir. We've been studying the choir for a number of years now, with great outcomes across a range of issues. We've got improved social isolation scores are improving, so people feel better, feeling more involved. We've got quality of life measures showing that people are feeling happier when they've been in the choir. We have large numbers of measures of voice strength and quality and intonation improving with the choir. Many of you will be aware that one of the things that can happen with Parkinson's disease is that all of that musical enjoyment, that excitement side, the intonation of your voice tends to drop. And so it sounds a little duller, a little bit more monotone. And we're showing that the choir really improves that, which you would think would occur. So our next step is that we are taking our concept of if you exercise the throat through using it, maybe the swallow and the voice, the swallow and the cough get better too. So we've got a new study occurring where we're asking people to come in and have some swallow and cough measures, so no x-rays this time, just some surveys and a cough strength where you blow into a tube, and we measure the strength of your muscles. And we're looking for people who have Parkinson's disease who don't go to a choir, who have Parkinson's disease who do go to a choir, and the same for people who don't have Parkinson's disease. So we want some age matched, so some people of the right age who go to a choir and some people of the right age who don't. So we're recruiting for this study at the moment. And as I say, if we can find these alternative fun therapy methods work, then we're moving in a wonderful direction for people with neurological disease. One thing we're very aware of is that, you know, boot camp works, but it's really hard work. And Parkinson's disease lasts a long time in your lives. So if we can find new ways that maybe you try boot camp in your first few years, but later down the line you've tried that and you haven't got the motivation for it, that maybe you can try something else. We all know that those gym routines are fun for the first couple of weeks and then our excitement dwindles. So if we can find fun things that are also enjoyable, then we're hoping that means that we can keep people using it rather than losing it for much longer. Okay, that's all we've got to show you. But we're
here. So again, thank you, ladies. A small gift from Parkinson's for each one of you. Hope you enjoy it. Thank you again for taking time. So if everybody'd like to say thank you. Thank you.